Okay. All right. Well, it's great to be with you. Larry and I have worked closely together. The way that we got connected, I'd been hearing his name around family medicine for literally decades, but I'd never met him. And I was on.
Say I'm old.
Well, we're both old, buddy. But
Yes, I am.
I was at Wright State University, and I would hear it a fair bit. And it was back during my Air Force days. So we got to meet when Bryce Heimbaum told me he was having to cancel my fishing trip with him up on the Lake Erie to go walleye fishing because Larry asked him last minute to come to the Innovators thing in, was it Rhode Island last year or something like that?
2 years ago, yeah.
Yeah, 2 years ago. So anyway, we got connected, and thankfully CHM has basically hired him to be my attaché, and he makes me so much more effective. So contact information, faculty disclosure, I don't have anything to disclose except that I work for CHM. And so I want to just tell you kind of a little bit of my story and then CHM's story, and then what brought us to where we are today. And some of the discussion, I think, is just very relevant to things that we're doing, and I hope that it gives you a little bit of hope, because sometimes these conversations can get awfully discouraging. So let me pull it up here. So when I was in college at Seattle Pacific University, I heard about this company called West Tours, where you could go up to Alaska and spend your summers up there working as a tour guide. And so I did, and I got a job working as called a motor coach commanders. We weren't bus drivers, we were motor coach commanders, and we would pick up loads of people, put them on a 45-passenger MCI coach, and we would drive them around the city or across the state. And I had noticed something about myself, that when I was in Anchorage at home and I was assigned a couple of city tours, I would pick up a load of people, give them a 2.5-hour city tour, drop them back off, and then go get the next load. And I never bothered asking any of them their names, where they were from, took zero interest in them because I knew they were going to be out of my life in 2.5 hours. But when I picked up a load in Anchorage and I took them across to Valdez and Toke Junction and Dawson City and Whitehorse and down to Skagway, I was with them for days. And I found that instead of just hanging out with the other tour guides, drivers or whatever, I would go have lunch with them. I would get to know them. I would ask questions. And I found that I was really energized by doing this. And while the rest of my colleagues were getting burned out by the end of the summer, I was still going strong. And there were a couple of us that really thrived on getting to know people and learning from their histories and so on. And that is what told me I wanted to be a family physician. It wasn't from working in medicine. I realized that I wanted continuity of relationship. And I liked getting to know people, and when I did get to know them, I found them interesting. And so with that experience, I decided to pursue the track in family medicine, and then became further convinced it was the right direction for me, because I preferred a broad base of experience and a skill set rather than being a total expert in a very narrow wedge of an area, and not really knowing how to connect the dots to the rest of the human body and so on. And I also wanted to be connected to not just that individual that was in my office, but to their family. And I liked being their go-to person when they had needs or concerns with regards to healthcare. And I also liked the fact that I was so broadly trained. I remember when I walked out the door at Martin Army Hospital with my residency diploma, I felt like I could do anything. And after a little bit of experience, I realized I couldn't do everything, but I sure was well trained. And I love the idea that people could come to me, and the vast majority of the time, and the statistics are anywhere from 80 to 90%, they didn't need to go elsewhere. If they needed a test, I could order it, or whatever, I could help them through that scenario. That's what took me into family medicine, and that's very relevant to what we're going to talk about. This is Bruce Hawthorne. He was in a Bible school down in Cincinnati when he felt like God was telling him to go work with alcoholics. And I've stayed in his home. He's passed away 13 years ago now. Interesting guy. He's a very fascinating guy. And so at the age of 21 or something like that, he goes and starts a homeless shelter in Barberton, Ohio, just down the road from here. And he and his wife, Phyllis, get this building, and eventually they move out on this 13-acre campus where it's still today. And he starts going around the country raising donations within his denomination to help fund this work with alcoholics. And the way I got connected to them was I started working at the second organization he founded. Well, this is a guy who was earning $8,000 a year on his salary at the homeless shelter, no insurance, and in 1981, he was traveling with his family near Toledo, and on his way to speak at a church to raise money for the mission, and got hit by a tractor trailer, and it took the life of his wife, Phyllis, and their youngest daughter, Elizabeth. And that was in 1981. And that experience, among some others, opened his eyes to the fact that there were a lot of people out there before ACA who had no health insurance, working for nonprofits like his that couldn't afford to pay for their staffs. And they couldn't afford to pay for it out of their own pockets. And so they were just one accident like that away from financial bankruptcy. Well, actually yesterday, just yesterday, I was out at the New Destiny Treatment Center, which is the organization that he originally started in 1961. And I asked the executive assistant if she had any old newsletters. And we went back through these newsletters and found the one in November 1981 that told the story about this tragedy.
Wow.
And that story going out to their 13,000 subscribers, they weren't subscribers, they just got the newsletter, and then they would occasionally send in $10 to help pay for things, you know. And the story went out, and people, there was this outpouring of compassion towards Bruce and his family. When I stayed in his home, he said he got all of these cards, these letters, and dollar bills, cash, checks, and he put it all into a brown paper bag, and he drove over to the hospital in Toledo, and he dumped it out on the clerk's desk and paid for all of his bills. And that's what made him realize that there are a lot of people out there like him. And so he sent out an invitation, and 212 people joined together and decided that they were going to pay each other's bills voluntarily. Now you need to understand this about health shares. There is no transfer of risk. The patient is 100% responsible for their bills all the time. The organization is like a clearinghouse. You send your bills in. They literally, in those days, you put them in the back of the line in the file cabinet, and you pay the bills as you go. Each month, it was called a newsletter. You get a newsletter, and if you can imagine this, in the 1980s, before HIPAA, you would get a newsletter each month if you were a subscriber. And it would have stories of people who were helped through this ministry, and maybe educational articles and so on. And you would get this newsletter, and on the back of it, over your name and address, was stamped the name and an address and the diagnosis of whoever submitted their bill that you were supposed to send your money to. And so you would, if you had broken an arm, let's say, and you had $3,000 in bills, and the gift amount for that month was $100, 30 subscribers, 30 subscribers would get your name stamped on their newsletter with broken arm on it. And then they would get a list of the 30 people that were supposed to send their gift to them, and then they would turn that into the headquarters. So it's pretty complicated. But that's the way they figured out how to do it. And by the time I joined them in 1995, John Hawthorne, his brother, and Mike Sharman, the attorney, had been in courtrooms and battles in 33 states, and they won every single one of them, except I think they called a draw in Delaware. And the argument was, are we allowed to do this? Are we allowed to do this as an expression of our faith? That we're going to bury you one another's burdens and so fulfill the law of Christ. So that's what they're doing. It started off with tragedy, but it led to innovation. So what were the results? Our current president, who's the third one, his name is Craig Brown, says this is faith, flexibility, and freedom leads to savings and medical autonomy. They tend to be focused on saving because they always have. What we're trying to do with Larry and me is to change them to be a little bit more clinically oriented, because actually my personal belief is if you can keep people well, they don't spend money on healthcare because they don't get sick, right? So the benefits are enroll anytime, you choose your own doctor or facility, you shop around, negotiate discounts based upon your cash pay or self-pay. If you do incur bills, submit them for sharing as long as they meet the eligibility guidelines, which the members have typically voted on and decided to do, then they get published. And if it's eligible, 100% of it gets shared. And they're currently passing around about $60 million a month.
Wow.
About $12 billion has been shared, more than that now. But the idea is, do we want to, Craig likes to say, are you a claimant, you know, with an entitlement mentality, or are you a consumer, actually a giver rather than a taker? And it's amazing. There's a page they call the prayer page, it's called something else now, where people will actually send in and give more. It's kind of like popular now, like GoFundMe type things, you know, that sort of thing, crowdfunding. So there's a downside to this happy story. One of the things that we've learned over the last few years is that just because somebody has freedom doesn't mean they know how to use it, right? And so our members have been told for over 40 years, you don't need to bother calling us. You get sick, you just go to the doctor of your choice, and we hope you get well. And then send us the bills when you're done, and we'll help them get shared. So the problem is they don't know who to call. They're going, I mean, we've literally had people call up one of our teams and say, yeah, I was told if I had knee pain that I should call you guys, and I think I need a total knee replacement, and they said if I called you, I wouldn't have to, that you'd waive my personal responsibility amount. And we said, well, what's your diagnosis? I don't know, I don't have one. Have you seen anybody yet? No. They hadn't even been diagnosed yet, but they went and they studied it up, and they think that they need a total knee, and so therefore they're calling us, all right? So they can lack credible information, get confused and overwhelmed. Many of them, my guess, because we don't know with 400, 500,000 people, but my impression is most of them are not engaged in primary care. Mm-hmm. And if they are, they think they have a primary care doctor, and it's a PA in the big system down the street who sees them for a few minutes and then gives them a referral. That's not primary care, but that's what they think it is. And then we think, because we've been more of a catastrophic loss prevention solution rather than an all-encompassing healthcare solution, that many of them are skipping their screening and they're getting diagnosed with their cancer at stage 3 and 4. It's extraordinarily expensive and not successful in many cases. So there's a downside. There's also what I've seen is a downside in the marketplace. And this really concerns me as much as what's happening with the patients out there. And that's in my fraternity of family physicians. Anywhere between, depending what you read, 50 to 78% are employed. The average wait for a family physician visit is 28 days. The average face-to-face time you actually get to talk to them is 8 minutes. I heard a story this morning down at CHM. One of our VPs did have a procedure done, and he went to get a medical clearance and saw somebody, and he had about less than 60 seconds of face contact, you know? And here's some other things. There's misalignment built in to being, now I'm not trying to step on any toes and offend anybody. I've been there. This has been my life too. But when you're working for a healthcare system that is not giving you the time to address your patient's needs and is incentivizing you either via time or financially, bonuses or whatever, or both, that's a misalignment. It's not in your patient's best interests. And I think it causes some personal injury when I get into a situation like that. And other things happen. We just heard earlier in the conversation, we want everybody to be practicing up to their full scope of practice, right? Well, what I see happening is family docs' skill sets are going through attrition because they're not using them, because it's quicker and easier just to get them to refer them out. And that's what many times the employer wants them to do, because then they can bill for 2 to 3 times as much for the same thing that you can do much less expensively at the family medicine level. And so therefore, guess what? You lose a sense of purpose, you lose your vision, you lose your passion, and you burn out. And it's happening big time, not just in family medicine, but across many other specialties. And guess what? And this is where you start getting people caring. You get poorer clinical outcomes, and you get rising costs. In other words, rising costs and poorer clinical outcomes go together. Just because things cost more in the U.S. does not mean you're getting better clinical outcomes. You're getting worse, okay? And in fact, if you put more family docs into a community, I assume that they should be independent, you extend life expectancy, something like 54 days for every family doc per 10,000 capita. All right, so there's lots of people in the marketplace. Some of you were asking about, well, where is this happening? Like one meeting I would love to see you go to is the Free Market Medical Association. It's once a year. It's usually in Oklahoma City or in the Midwest. It's a great meeting. It's usually around the end of April, early May. And that's the meeting that we flew our CEO to 3 years ago, and it changed everything at CHM and what we're doing. Okay, that's one great meeting, as well as Rosetta Fest, which is usually in September. And I think it'll come back to Denver, I think they said, next year. Because, yeah, they're coming back to Denver, the same place. I was talking to Laura about it. Okay, so these people, I've all met them personally. There's Dave Chase, Relocalizing Health. Look at this. The future of healthcare is local, open, and independent. Farouz Danishkari from our backyard here down in Bath started a company called Bowtie Medical, and I'll share you something very important that he had to say with me. Marty McCary, I believe he's now at the FDA, but he's written Blind Spots, keynote speaker at FMMA, and also written at Rosetta Fest. Great guy. All right, so I'm having dinner with Farouz Danishkari. Okay, so that's enough of the problem, right? I'm going to tell you what you were doing about it now. So we're sitting at dinner right down here, and he draws out this thing that's a bow tie. Well, come to find out, bow tie is a risk management model. It's a way of kind of graphically demonstrating safety problems, risk, and then how to manage them. So he draws this out, and he says, the knot in the bow tie is your medical event, and then you've got downstream effects of that. What was the clinical outcome? Did the patient get well, or did they have disability? And then secondly, what was the financial cost of what happens? And so these are your downstream effects. We really didn't talk about what was upstream to that. But from that conversation, I found that diagram there so helpful to be able to explain to non-medical personnel. You talk about people not speaking the language, and that's what I find at CHM. I'm talking to people who have been helping others get their bills paid. They've got no clinical training. I'm trying to explain to them why primary care is so important, why prevention, wellness, wholeness, and they got to see the numbers, and sometimes the numbers are hard to find. So what I did was, we took that information, and I told them, these are the people I'm meeting: Farouz, Bryce, and a number of others. And I sat down, I got asked to brief the executive team in February of 22, and I had pulled up that bow tie and I said, this is what we've been doing for 41 years. We're just focusing on the cost. You've heard that analogy of babies floating down the river and jumping in and rescuing one, and then you see another one, and then another and another, and so you keep on trying to rescue them, and finally somebody asks, well, maybe we should go upstream and figure out why all these babies are floating down, right? In the same way, we're incurring all these costs, and the costs are escalating unbelievably, and with no rationale for them. Maybe we should go upstream and try to figure out what's going on. So that's what we did. And we got Craig onto a plane, flew him to the FMMA meeting, and we started talking. Well, the first thing then we began to realize is that we could do better on preparing for cost if we put together reference-based pricing, and let's say, okay, we found out that that two of the major healthcare systems in Northeast Ohio are charging something around 700% of Medicare. That's pretty standard. And we're appalled. And we had been so excited because we were getting 20% off. 20% off what? and so we started looking for reference-based pricing. And then even better yet, can we bundle things in advance and pay them up front or at the time of service with no downstream billing coming in? Can you imagine that? I don't get bills for the next 6 months from not only the doctor, but the surgeon, the radiologist, the anesthesia, and all that sort of thing. It's all done at the time of service. And then we started looking at trying to build relationships with facilities that were known for their excellent outcomes, even maybe centers of excellence for those particular problems. And then we realized, you know what? In order to get people to go there, we need a nurse navigator. So we contracted with Bryce Heimbaugh's Concierge Nurse Navigators to give us nurse navigation. And the first team that we were allowed to pilot this with was our maternity care team. So we hired a nurse navigator, and we incentivized our members, if you call within your first 16 weeks of pregnancy and talk to us, we will waive $500 of your personal responsibility amount. And we were amazed by how many people called because they were going to save $500. And so we got engagement with that. When we were afraid we weren't going to get any because we've been telling them for 40 years, don't call us, okay? And then it worked so well, and the outcomes were so much better in terms of their patient satisfaction that we started something else, and it's now called Complete Surgical Care Solutions. And on the first case that this happened, Larry alluded to it earlier. Let me just tell you the quick story. So in Indiana, there was a gal who was in her early 20s. This has all been publicly released. It's on a video. And she said, I just had my first baby, and during my pregnancy, I was noted to have SVT. My heart rate was going sky high into the 200s. And my cardiologist told me I could be on medications the rest of my life, or I could get a cardiac ablation. It would be curative, and I would be done. And so she said, okay, what did they quote you a price? Yes, $85,000.
That's a lot.
And they want it up front because it's elective. And so somebody did a little math at the office, and they said, well, I'm sorry, but that's well above fair market value in your area, which I didn't even know there was such thing in medicine. But Healthcare Blue Book or something like that they looked at. And so the conversation went something like this. So we cannot share for it or pay for it up front. You're going to have to come up with that $85,000 yourself, like, I don't know, take out a second mortgage or something, pay for it, and then turn your bills in, and it's taken us about 50 days or so to get them shared, and then we'll pay for that. Or, you are our first caller. If you would be willing and interested, we will put you and your husband on a plane. We will fly you from Indianapolis down to Oklahoma City. Oklahoma Heart is a center of excellence for cardiac ablation. They will do the procedure for you. You will have zero out-of-pocket costs. We'll take care of your travel, your rental car, your hotel, and take some pictures when you go, and it'll be $27,000 plus the travel expenses. And so, are you interested? Yes, absolutely. So if you can imagine this, she's going through the Indianapolis airport, and she's got her iPhone going, we're on our way to get a cardiac ablation down in Oklahoma City. And this speaks to something else that we realize that we want to see. So we've added 2 additional things that I'll mention, but we want to get 4 things here. And one is we want the best possible clinical outcome, and that implies quality and appropriateness of care. You can go to a great surgeon, but if you're having a surgery you really don't need, who cares about quality, right? Being conservative, appropriate cares. And we want the best cost outcome that we can get within reason. We want people to get paid, but we want it to be an honest wage, right? And then thirdly, we want the patient, the member, to have the best experience they can. We want them to feel cared for. We want them to be stronger and more resilient regardless of what the first 2 outcomes are. And we want them this to be a good positive experience for their family. And it's been amazing when they call and they find out that hey, we've already thought this thing through for you. We got some answers for you, and here's what you can do. And it's just very, very cool. And then we want the clinical team that takes care of them to prefer them as their customers, because it was such a beautiful experience. They all got paid the day the service was rendered or a couple of days later, and it wasn't chasing down and fighting over bills and rejection and all those sorts of things. So those are our goals, our 4 goals of that. We now have the maternity care solution, the complete surgical care solution. We have a cancer care solution, which we just launched less than a year ago, and we're working that up and building a clinical review process. I mean, it's just an enormous amount of work, and we're trying to decide how much should we be taking on here, and we're building partnerships and so on, but if you can imagine, it's a big thing, a mountain to climb. And then HealthTap is an interesting telehealth service that was developed by one of the co-founders of WebMD and Hippocrates. Anybody ever use that? So Jeff Rutledge is one of the guys that developed that. He's the chief medical officer and co-founder of HealthTap. He's an internist and an emergency medicine doc who became convinced of the value of primary care. So they built a telehealth platform that provides an urgent telehealth service, urgent care, but their main goal is to try to get people to migrate over to primary care and actually pick their doctor and establish a longitudinal relationship with them. And even if they do have a local primary care physician or nurse practitioner or whatever, oftentimes they have trouble getting in and seeing them. And so this becomes sort of an augmented type of thing. Frankly, I think all of those things needs get met better in a direct primary care practice, as long as the person is really there to provide those services to their patients, and most of them are. So we've done that. Now, there's a couple of things. So upstream, we can put together agreements and things like that so that if and when there is a medical event, we accomplish these 4 outcomes downstream. But we also really are starting to look, just starting to look at risk management. And where's all that money going anyway? And what do our members need? And then should we be designing strategies to mitigate the risk for that? And that then gets down to prevention. And so we are not at an ideal state by any stretch of the imagination, but we have done enormous things. There's been incredible change based upon what we've done in the last 3 years compared to the first 41. And I think we have a model that we can use to try to go into the future, but these are some of the innovations that are used. And guess what? The doctors that we're looking to work with are independent, local if possible, and I just want to say one final word. One of the things that has become that I have become absolutely convinced of, that if any solution that is being promoted out there does not include a family physician at the core of it, that's an independent practice and not in a misaligned relationship, then it's not going to work. I mean, I guess you could be in, you don't have to be an independent practice, but knowing human nature like I've gotten to know it with all my gray hair, you know what? Better be independent. That's probably the safest way to go. And so I think that the things that you're talking about that are happening, lots of docs, I've never been in a happier group of family docs than being at a DPC meeting. They have come to love life again and love what they're doing. And it's very cool. And I'm not really throwing a pitch for them intentionally. I'm just saying that trying to solve this thing without family medicine, we are the ones, because of the reasons I said I went into family medicine, we are the ones that are actually positioned to answer the call for what our nation needs. And that is access to care, quality, broad spectrum of training, motivation to keep costs contained, and to handle things at the lowest level necessary. And then my dream state with CHM is that whenever one of our members comes in to see that doc and they need something that doc can't provide, then they pick up the bat phone and call us and we say, okay, here's some options for you. And you can send them, you know, you take your pick, you keep the decision making between the two of you. We're in the background to provide these wraparound support services to you, but not take away your medical autonomy. Okay? Is that good? Anything else? Yes?
Okay, so I have a couple questions, but I'll start with the first one. Have you guys had conversations about just, you know, humans need to be incentivized to do things, even things that are good for them, so, or good for us?
Yes.
So a lot of like small incentives, like